Today's topic is Chapter 48 from TIMBY, Caring for Clients with Ostomies. Our learning objectives include knowing the difference between ileostomy and colostomy, explaining how stool is excreted from 3 types of ileostomies, describe the 2-part procedure needed to create an ileoanal reservoir, discuss various types of colostomies, explain ways that clients with descending or sigmoid colostomies may regulate bowel elimination, discuss preoperative nursing care of a client undergoing ostomy surgery, list complications associated with ostomy surgery, discuss postoperative nursing management of a client with ileostomy and colostomy, describe the components used to apply and collect stool from an intestinal ostomy, cite reasons for changing an ostomy appliance, summarize how to change an ostomy appliance. So, an ostomy is an opening between an internal body structure and the skin. There are different types. There's an ileostomy, is an opening in the distal small intestine. There's a colostomy where the opening is at the colon. The stoma is the opening itself. Exterior abdominal surface is where it's located, so on top of the skin. The causes of reasons for ostomies are inflammatory bowel disorders, rupture of intestines, irreversible obstruction in the bowel, compromised blood supply to the intestines, or a cancerous tumor. Is the following true or false? A colostomy is a surgically created opening between the small intestine and the skin. The ostomy appliance used in this case immediately postoperatively can be disposable. It's in the immediate post-op phase that you use this, and then eventually you'll go to reusable equipment that will be fitted exactly to your stoma. And as far as disposable equipment, that can be replaced daily with bathing. And immediately post-operatively, in this case, the stoma will continually release gas and stool. The stool will be probably liquid or mushy or pasty and contain, like I said, the digestive enzymes and acids. The preoperative period is lots of teaching and explanation by the surgeon for the purpose, the benefits, and the risks of this surgery, what the stoma is going to look like, the function, and the site will be marked as to where it will be. There's also enterostomal therapists involved, and therapy nurses, wound care nurses, all collaborate with the surgeons and clients' educational needs. They also will explain risks from the total colectomy, which includes bladder and sexual dysfunction, because there's a risk to the parasympathetic nerve. And so there's a possibility of infertility and impotence. So the males need to be prepared to possibly collect and store sperm, and fertility will be slightly diminished as far as occurrences in women.
So sometimes after a total colectomy, there can be some possible bladder dysfunction, sexual dysfunction, and this is because there might be some injury to the parasympathetic nerve. Now, sexual dysfunction in men after a total colectomy is unusual, but it does occur sometimes. So, if such a dysfunction persists after a colectomy, we have some operative and non operative options that are available to facilitate erection for these men. Sometimes for young men, we might give them information on collecting and storing sperm for later use if they plan on having children. A colectomy for females, it might slightly diminish their fertility, but it doesn't necessarily mean that they cannot have a full-term pregnancy with a normal vaginal delivery. We also want to, before surgery, we want to cleanse the bowel. We might give them some dietary restrictions in combination with some laxative or lavage agents, and that's Go Lightly, Miralax, Ducalax, things like that. It kind of depends on the client's condition. So this means, do they have an obstruction? Do they not have an obstruction? It can also be on surgeon preference as well. So these kind of things we have to take into consideration. Also, again, with surgeon preference is the use of antibiotics. So some surgeons might want antibiotic prophylaxis, and a lot of the surgeons will order a combination of IV antibiotics, such as cephalosporin or metronidazole before surgery, and they'll continue it after surgery. Um, we also, for prednisone, if the patient is on prednisone, we're going to make sure it's tapered and discontinued before surgery because we want to avoid negative effects of the drug on tissue healing. But we also might give a preoperative stress dose of IV steroid, such as hydrocortisone, and it's given to clients who have been on prednisone within the previous 6 months. And this, if we give the preoperative stress dose, when they've been on it for 6 months or longer, this prevents adrenal crisis. So if you guys remember, adrenal crisis is a potentially life-threatening, and can result from the abrupt withdrawal of corticosteroids or significant stress after the client has been treated with corticosteroids.
Tapering off the corticosteroids and watching for the side effects is preventing adrenal crisis. The ileostomy preoperative period also includes discontinuing any aspirin-containing compounds to minimize the risk of bleeding, also any NSAIDs or any herbal medicines, and obtain lab samples and blood type and cross-match for replacement of blood loss. Is the following statement true or false? Discontinuing the use of aspirin before surgery decreases the likelihood of excessive bleeding. And the answer is false. Discontinuing the use of aspirin before surgery decreases the likelihood of excessive bleeding, as aspirin side effects include anticoagulant properties. In this particular ileostomy, the rectum and the colon were removed. So for surgical management, the patient will have a rectal pack which absorbs drainage, promotes gradual healing, and they keep it on for 5 to 7 days. Irrigations will be done to promote healing into the stoma, and also an NG tube will be used to provide comfort from the compression in the GI system. So basically it's going to allow air to vent out of the system with the NG tube, which is called gastrointestinal decompression. You're going to have IV fluids running. You want to maintain fluid, electrolyte, and nutritional balance. You're going to give antibiotics and analgesics for pain, and you're going to monitor wound healing. You want to watch for complications of intestinal obstruction, which is a serious complication. So if there's nothing coming out of that stoma, that's a reason for concern, especially initially. As far as the stoma goes, like I said, you may need to irrigate it if it slows down. PRN with normal saline. Keep the area around the stoma clean. Change the gauze frequently around the stoma. Check the skin frequently, and keep an eye on the drainage. Post-op management continues as far as watch the stoma for bleeding, which a little bit of blood is normal after surgery. Also watch for prolapse, which is the stoma sinking down underneath the skin, or excessive protrusion of the stoma. In these cases, you definitely want to let the surgeon know. Also, if there's prolapse or protrusion of the ileostomy itself, Any edema or obstruction, again, restricts normal blood supply, which causes necrosis if the prolapse is not managed promptly and skillfully, so you need to let the surgeon know. Now, this is a different kind of ileostomy. It's called a Koch or Kock pouch. This is an internal reservoir for the storage of GI waste, again, internal in the body. This one, the reservoir that holds the waste inside the body is formed with a portion of the terminal ileum. It has on the end of it a nipple valve. There's a temporary catheter insertion, and basically this allows the patient to be continent, meaning that they can drain the pouch themselves when they need to, as opposed to it just leaking out, and there's no need for any appliances. Again, if there was any surgery in the colon or rectal area, there would be a perianal pack remaining for a week for healing. Is the following statement true or false? A Koch pouch is used to facilitate a continent urostomy. This is a false. The Koch pouch is used to facilitate a continent ileostomy. Now we're going to talk about the post-op management again of the Koch pouch. We're going to reinforce perianal packing, check the abdominal dressing drainage, connect the stomal catheter to low intermittent suction, and check the ileal catheter for any obstruction. You're going to note the drainage, the color, the amount, and observe the stoma size and color. You're going to administer irrigations of catheter saline solution routinely and as needed. You're going to keep the skin clean around the stoma, change the gauze dressing, monitor ileal output, notify the provider if there's anything abnormal. You're going to empty the reservoir and teach your patient how to do that. This is the most common type of ostomy surgery. This is the Ileoanal Reservoir, creating a J pouch, and also called an S pouch, that will eventually require additional surgery. This is an ileoanal anastomosis. It maintains bowel continence is the advantage. Clients with ulcerative colitis will be using this, and it preserves innervation of the male genitalia, meaning there's no problem with the parasympathetic nerve being affected. And bladder and erectile dysfunction is unlikely, and it also does not affect fertility. The first stage in this surgery is the temporary ileostomy, which is going to have continuous discharge of mucus from the anus. There's going to be frequent discharge of fecal material from the ileostomy and uncontrollable watery discharge. Now, there's two parts to this. So the second stage of surgical management is 2 to 3 months later. They close the temporary ileostomy and they reunite the two sections of the ileum. Fecal material is expelled. There is control, and there is a stronger anal sphincter because of this. The pre-op management is the same as for an ileostomy. The post-operative care in the first stage would be observations, especially the anal area for drainage, and the drain or drainage tube in the pre-sacral area. Post-operatively, the second stage would be drainage from the anal area and operative sites that you'd be watching for and observing. And then you want to instruct the patient on perineal exercises, and bowel incontinence relationship to, and to keep the perianal area clean. Post-operatively, you want to, in the first stage, you want to teach the patient to use a squirt bottle for cleaning. After the second stage of repair, you want to instruct the client to cleanse the anus with warm soapy water and emphasize to dry the area well. Now we're going to talk about colostomies. There's going to be an opening in the large bowel. The reason for the colostomy is cancer, ulcerative inflammatory processes, multiple polyps, and injury to the bowel. There's different types. There's temporary, permanent, ascending, transverse, descending, and sigmoid. Is the following statement true or false? A colostomy can be either temporary or permanent. The answer is true. A colostomy can be either temporary or permanent. It is also referred to by its placement. There are differences in the management of the colostomies. There are regular irrigations that control sigmoid and descending colostomies. There's also appearances that are different, single barrel versus double barrel versus loop. The loop would be part of the double barrel. Surgical management, in terms of the types of barrels, the single barrel is a single stoma, a segmental resection, an abdominoperineal resection with tumors that were in the lower third of the sigmoid. The double barrel stoma is proximal and distal, and the duplicate medical record diagram nursing care plan is to assess bowel function, and irrigations are required. In regards to the single barrel and double barrel stoma colostomies, they're treating disorders such as acute diverticulitis and chronic constipation and inflammatory bowel disease. The interval before reestablishing is 16 months or longer. There is also a loop colostomy, and so I'm correcting myself. The loop of bowel is lifted and supported with a glass rod or a plastic butterfly device, and the opening of the intestinal loop and bowel does lack pain receptors, so you don't have to be concerned about that. So for a loop colostomy, you want to protect the bed and client's clothing when the loop colostomy is opened. Prepare the client for a pungent odor of fecal material. The temporary ostomy pouch that they're using receives flow of liquid feces. Nursing management preoperatively is the same as ileostomy, and also anxiety related to the cause for the ileostomy or colostomy, especially in cases of cancer. So you want to recommend for regular bowel elimination, you do not want to use laxatives. You want to recommend suppositories, prune juice, fiber-rich foods, or stool softeners. But again, no laxatives. You run the risk of a fluid imbalance and electrolyte imbalance. Thank you.